welcome to this symposium titled Unlocking Efficacy, Expanding Access to CAR-T in Lymphoma and Myeloma from Practice-Changing Evidence to Real-World and Outpatient Experience. Please find your seat and let's get started. I have an awesome set of panelists today, including myself, Oluwole, Veronica Bacanova, and Yelene. We'd like to extend thank you to Peerview and the Medical College of Wisconsin, as well as BMS, Janssen, Legend, Novartis for making this symposium possible. And look out for polling during presentation. We expect a good interactive time and ask us questions which we can answer towards the end. You will have access to these slides, but you'll be able to download them later. So this is our first set of questions. Reflecting on your practice, select the options you think represent a challenge or unanswered question related to CAR-T therapy. Of course, you can select as many as apply. So the goals for today are to improve your understanding of evidence and real-world data supporting CAR-T therapy in lymphoma and myeloma, provide you with guidance on integrating CAR-T into management process, equip you with skills you need to address practical aspects of the CAR-T process, referral, outpatient therapy, and other considerations, including toxicity management. So I'm going to get started talking about the power play in lymphoma, the clinical evidence, and emerging strategies with CAR-T standards. So these are approved indications for CAR-T in lymphoma: T-Sangelacleucel, brexucabtagene autoleucel, axicabtagene ciloleucel, and lisocabtagene maraleucel. An important fact is that the FDA has approved a manufacturing process change that actually shortens the time of manufacturing of axicel to 14 days from 16 days. Whereas this may look like 2 days, but we treat these patients and we know that anything you can do to get product to patients sooner will be better. In other words, those 2 days may be the difference between being able to get the CAR-T and not. So, of course, we always want faster manufacturing. So we'll switch gears to talk about real-world outcomes or DLBCL and some more mature clinical trial data for follicular lymphoma. So we know, or we recall, that ZUMA-7 was a very important study for CAR-T. It delivered overall survival benefit, and it showed that patients could actually do well with CAR-T rather than chemo and auto transplant. Okay, fine. Maybe that was only the clinical setting. How does this shake out in the real world setting? It was refreshing to see that even patients who would not have been eligible on the ZUMA-7 trial for whatever reason, usually organ dysfunction, they still seemed to do as well. And with toxicity profile that was pretty similar. So that was a good thing to see that it worked in the trial, and in the real world setting, it seemed to be similar. How about lisocabtagene maraleucel? The data I'm going to present here is only for the conforming product. As you all know, there's a certain percentage of those that are non-conforming, and that is not in the scope of this therapy, because even though those were intended, they got it on an expanded access method. But it's refreshing to see also similar pattern that even patients who are older, age greater than 65, and those who will not have been eligible for Transcend trial still did benefit from the therapy pretty much as good as it was on the clinical trial. Even in the toxicity pattern, it seemed pretty aligned. CRS 51%, ICANS 30%, of which only 7% were grade 3. So this continues to hold true even in the real world setting. Although again, this is limited to patients with conforming products. So how about clinical trial? We now have longer term data for the ELARA. We also have longer term data for ZUMA-5, and they continue to hold true. This is one reason why it is good for patients to go on clinical trials. They get the early exposure to some groundbreaking therapy, and it's good to see the flattening of these curves on the end. Well, are they curative or not? Maybe. I think they probably are. At least why would a POD24 patient stay in remission this long? But we shall see longer term data about curative potential. How about lysocell? Also similar The follicular lymphoma studies continues to show very high objective response rates closer to 100 and CR pretty high. Longer term follow-up are needed, but these therapies with longer follow-up have continued to show great benefit to patients. So I'm going to pivot now to what is coming down the pike. We've already talked about what is. We are going to talk a little bit about the next wave of things coming down the pike, particularly in terms of faster manufacturing. And I already mentioned a little bit about the FDA approved process change for Axicel for faster manufacturing. So let's talk a little bit about RAP, Captagen Autoleucel. Although they said manufacturing time of less than or equal to 2 days, that doesn't really capture all, but it's very, very important because there is cryopreservation on the front end and there are release criteria testing on the back end. Either way, whatever you can do to shorten manufacturing is always appropriate. Then the question is, okay, fine. How does it work with the shorter manufacturing process? So we have one clinical trial that has been presented, at least in part, showing that it really doesn't work any less, maybe a little bit more than what we are used to, the one that took the longer manufacturing. So even though they also tried a lower dose of lymphodepletion because the standard is 30 like 500 flu-cy, but going down on 25/250 was also an exploratory test in this study. And it's good to see again from that tale that this did work very well and patients got good benefit with minimal toxicity as displayed on the slide. So we'll pivot again to practicalities of CAR-T in non-Hodgkin lymphoma. So I want to talk to my panelists to kind of chat a little bit about a patient. This is a 65-year-old man with high-grade double-hit large cell lymphoma. He was treated with R-CHOP and then promptly relapsed 7 months later, which unfortunately can be the case. Of course, this patient is now completely refractory. And we know based on scholar data how patients who have refractory lymphoma would behave. So this patient was then referred to CAR-T. So I'd like to ask Dr. Bakanova, what are your thoughts? When is an appropriate time to prepare for the referral or to even do the referral? This patient may not be curable with chemo. Do you think CAR-Ts have a chance? And would you think this could be done outpatient?
Yeah, so this is an older patient with a high-grade double-hit lymphoma who relapsed within 1 year from starting the therapy. So that's the first decision maker. Is the relapse late or early? So clearly this is a patient who is not going to be cured with chemotherapy. And we now have a randomized data from the couple of studies showing that CAR T-cell therapy is in fact a preferred modality to cure still this disease with a CAR T or cell therapy. So this patient needs to be, in my opinion, should be referred, or the CAR T cell path should be discussed with the patient. He has a high-risk disease. He's already having growing adenopathy, high LDH, so he's very likely going to need some bridging therapy. But at this time, he should be referred for a consultation, a discussion. And the CAR T cell therapy in this instance does have a curative potential. The autologous transplant would be inferior in terms of outcomes. And for most centers, it won't be offered for a patient in this situation.
Thank you very much. I couldn't agree more. The intent for the R-CHOP was curative therapy. But if they get to CAR-T, that could be a potentially curative therapy for them too. So we'll quickly discuss a second patient, Michelle, who is relapsed again, POD 24, and they went on to receive R squared, and then they received epcoritamab, although we know that some other bispecific could have been in that space also. She's now age 75. I think the question now will be, again, Dr. Bakanova, what are your thoughts? This patient is now 75 and they received multiple lines. Should they have received CAR-T earlier?
Yeah, so follicular lymphoma is a disease which is more indolent, but there are some subsets which are behaving in a more aggressive fashion, such as those patients who relapse within a 2 years, so-called POT24. There are many factors which really are judged when the next line of therapy is considered. Age, comorbidities, performance status, the overall organ function, where the patient lives, what the support, what kind of family support he has, and certainly some preference on the patient's part. But you could still argue from the data available that CAR T-cell therapies, particularly liso-cel, is reasonable to be offered in a patient regardless of the age. And follicular lymphoma has wonderful outcomes with liso-cel. So as we just saw, 90% of the patients respond. Whether you use it before or after bispecifics is an important question, which we have limited data on, and we can discuss it further in our meeting today.
Okay, Dr. Lin, quick question. Will you consider age? I mean, at what point will you be worried about age in CAR-T patients?
Sure. We've seen this both in lymphoma and multiple myeloma, where these are cancers of older patients. And so we don't necessarily think strictly of biologic age so much as functionally, how resilient they are, their comorbidities. So there could be a relatively younger patient who have heart disease, COPD, and end up being hospitalized with every infection. That's probably not a good candidate to think about, could that patient safely make it through CAR T? But on the other hand, a 75-year-old with no other major comorbidity, and the symptoms are mainly, let's say, from the lymphoma, would be a very reasonable candidate to consider for CAR T. I think these clinical trials are looking at formally measuring frailty as one of the considerations for CAR T, and it's important to see those data come through.
Thank you very much. Awesome. So we'll then go to this same case again. 75-year-old, should she have received CAR T earlier, and why? Okay, yeah. We would like them to have received CAR T earlier because it is potentially curative, even though they are 75. All right. Talking about management of CRS, there hasn't been much change other than, again, encouraging the use of tocilizumab and corticosteroids earlier so that patients do get prolonged toxicity. And also to try and use more supportive care in the management of patients. One other thing, and I'm beginning to round up, is infection complications. We tend to see this a lot, particularly as patients go further out. This is potentially curative therapy, or at least to give them long, durable responses. But what happens on the back end after they've had their CAR T is very important, close monitoring. So we recommend, these are some of the recommendations for antibiotic therapy to help mitigate the risk. Thank you very much.
All right, I will then speak on some of the current data for CAR T in multiple myeloma. So the last 4 years has been very exciting in the treatment landscape for multiple myeloma. We've had ide-cel and cilta-cel approved in 2021, 2022, and then 3 bispecific agents, 2 targeting BCMA and 1 targeting GPRC5D, with teclistamab, elranatamab, and talquetamab all approved. And with ide-cel, cilta-cel, with the randomized control study meeting their primary endpoint, we'll review those data shortly, leading to FDA approval for the use of those 2 CAR Ts in earlier line setting. So this is the results from CARTITUDE-4 study, in which patients were with 1 to 3 prior lines of therapy, are randomized to receive either cilta-cel as a single dose with no maintenance, or standard of care triplet, which were mainly DPD or PVD. And this study, as I mentioned, met its primary endpoint, which is improved PFS. So you'll see here a pretty impressive hazard ratio of 0.26. Also to note here, the bridging therapy that's used during CAR T manufacturing is the same as the standard of care treatment option in the standard of care arm. Later today, actually, in the lymphoma and myeloma session, we'll be presenting on the longer-term follow-up MRD studies on this clinical trial as well. Now, what we have seen is that across all the pre-specified subgroups, including many features of higher risk, such as older age, higher disease burden, in this particular case, looking at high-risk cytogenetics, the improvement in PFS and response rates are seen across all of those groups. Similarly with KarMMa-3, now this is a different randomized control study. It is for patients with 2 to 4 prior lines of therapy, where patients are randomized to receive either ide-cel, again as a single dose infusion with no maintenance therapy, or a number of different standard of care combination regimen per physician's choice. Here again, you see a very impressive separation of the PFS curve. So also met its primary endpoint for improvement in PFS. And it's important to note that for this patient population, when we're talking about 2 to 4 prior lines of therapy, because the myeloma patients are receiving combination therapies from the first line onwards, these are in fact actually patients who are already fairly refractory to a number of our initially effective combination treatment. Now, the management to get patients to CAR T dosing is very much the art of science of delivery. CAR T only works if the patient can receive it. So managing the disease while the CAR Ts are being manufactured is key. And right now, for both of these products, the door-to-door delivery time can be longer, can be on the average of 1 to 1.5, sometimes 2 months. So this can translate into more than one cycle of bridging therapy. What we have seen from the KarMMa-3 study is that by physician's choice, so often depending on what the patient has seen already for prior treatment, what their disease were refractory to, a number of different regimens were selected. Now, not surprisingly, some of the more contemporary combinations, such as DPD or KD, were more effective at debulking the disease during the CAR T manufacturing time. And this can be important in terms of both the safety for the infusion of the CAR T cell, for some of these immediate toxicities with CRS, as shown previously even in a lymphoma study. But also you can think about it as the effector to tumor cell ratio. The lower the disease burden, the more likely that the patient could have a higher or more prolonged PFS. Now, in the real world, what we have seen with the US Myeloma Immunotherapy Consortium, where now we've had hundreds of patients treated, and in fact, more than 3/4 of those patients would not have qualified for the registration study, the initial single-arm registration study, in this case, KarMMa-1 for ide-cel. We are seeing that overall, the safety signal is very comparable, and the response rate PFS benefits are still shown for this real-world patient population. Not surprisingly, there can be a little bit of a drop for patients who would not have met KarMMa-1 criteria, but you're still seeing that PFS benefit there. Particularly as in multiple myeloma, CAR T is the only treatment we have with no continuous maintenance treatment. So even if these patients currently, with the current available CAR T, may still eventually see that relapse, that duration of time that they're not receiving any treatment is a huge quality of life benefit for them. And in fact, may help reset the immune system and the type of response we may see in next line of therapy if and when their myeloma relapse. Similarly, for Sotocel, in the real world experience, this was just recently published at the end of 2024, we're also seeing that a high percent of these patients may not have qualified for the CARTITUDE-1 registration study, but we are still seeing a very nice response rate and PFS, at least in the limited short follow-up that we have in the standard of care practice. Now, as I mentioned, bispecific antibody is also now available in the treatment landscape. And we are really trying to understand where's the best opportunity to use these, what is the role for potential sequencing of these therapies. So in this real world experience, what we have seen is that if the patient has had prior BCMA exposure, they're less likely to have that prolonged PFS to CAR T treatment. And there may be a difference in the relative time frame of exposure. So in this particular case, if the patient has had BCMA targeting therapy, and this include antibody drug conjugate, bispecific, or CAR T, if that exposure is within the 6 months of consideration of going on to CAR T, that's where you may see the most detrimental effect. Finally, I'll point out this largest meta-analysis that has been published to date, looking at over 7,000 patients across clinical trials and real-world experience. And this is across all conditions: leukemia, lymphoma, myeloma. And what's really notable is when you look at that non-relapse mortality, even though we do talk about CRS, neurotoxicity, these are very important immediate side effects to manage. But when you look at the overall non-relapse mortality, more than half of those are really attributed to infection. So as already mentioned in the prior session, really understanding that immune reconstitution, how to monitor for it, what prophylactic measures, and then how to manage the infection are key to help with survivorship with this therapy. So what's coming next for multiple myeloma? I think a lot of really exciting things in clinical trial. Anito-cel, with the data just recently presented at ASH meeting, that is now into registration study. Now, this is a novel engineered CAR construct, so has the hypothesized advantage of being less immunogenic and also potentially better targeting the BCMA target. And so what we have seen so far with this particular construct is that it is having a very high response rate. You'll see here ORR 97%, stringent CR rate very high and likely to continue to deepen over time, as we've typically seen with CAR T therapy. And what's also very exciting with this particular CAR T in the registration phase is that the collaboration with Kite Gilead, where the aim is to shorten that manufacturing time. So this may be a product that could potentially have a shorter door-to-door time and increasing the odds that the patient might be able to make it to dosing. Now, in advance of shortening that door-to-door time, we have even rapid manufacturing CAR T as well in multiple myeloma. This particular example, the Fast T CAR T platform, this particular data, again, showing very nice, very high response rate, is results coming from China, but the US multi-center study is currently now open. Here it's targeting both BCMA and CD19. I think the target is almost less important, whether there's a lot of discussion in terms of is CD19 a marker that could be on a progenitor plasma cell. and potentially contributing to the efficacy of this product. But what's really important to note here is when we look at these rapidly manufactured CAR T, so we're talking about 1 day, 2 day manufacturing, not surprisingly, the less time these T cells spend outside the body, the less exhausted they are. And so what we're seeing is, from even a safety reason, these patients can only receive log-fold lower dose of these CAR T. So now you have a product that could be made much faster, and you actually don't need to make as many of those. They can be just as potent. And so that's a very exciting advance to watch out for in the field. And then lastly, I'll mention, we do have talquetamab, a GPRC5D targeting bispecific that's already approved for use. And we do have GPRC5D targeting CAR T also in clinical trial. So this is the latest data from Arlocell. Again, noting here very high response rate. What they're seeing so far across different high-risk features, including extramedullary disease and so on, the initial response rate appears to be quite high. We have to learn at this time in terms of some of the additional toxicities neurologically that may be seen with the BCMA and GPRC5D targeting CAR Ts. In general, these can happen closer to 1 to 6 months post-infusion. So that's a time frame where the patients could have left the treatment center for some of that immediate toxicity monitoring. And so on average, these are not very common, but side effects that's important to watch out for and to connect with the CAR T treatment center as we're all learning how better to identify it and manage it. So coming back to a couple of cases here, after showing you the data for CAR T and multiple myeloma. So here we have Max, a 63-year-old gentleman with IgG kappa myeloma, again, high risk by ISS3, fairly good performance status of 1. This patient has only had first-line treatment with RVD, followed by autologous stem cell transplant, and has been on lenalidomide maintenance, and is now about 20 months, within 20 months from stem cell transplant, and is having evidence of relapse with rising M spike and free light chain. So now we're talking about a patient who's after 1 line of therapy. Is this patient a candidate for CAR T? And I'll just open it up for my panelists to see what you guys think.
Yes, I think I will consider this patient for CARVYKTI because number one, usually when patients have myeloma, they get the induction, then they get transplant or not, then they get maintenance. So they've been on treatment continuously for a long time. But if he gets this CARVYKTI based on evidence, maybe he's going to have a good treatment-free period that will be pretty durable.
Yeah, I think that's definitely a very reasonable consideration. This is certainly the setting from the CARTITUDE-4 study. So one, we know in general, relapse within 2 years after autologous stem cell transplant, regardless of whatever high-risk features of the myeloma going into treatment, by itself is a biologic aggressiveness feature. So this could potentially be a patient that would benefit as CARTITUDE-4 is designed, especially considering the benefit of the treatment-free period. Now, of course, this patient hasn't really had any of the other, myeloma targeting drugs that we would have had. And so some of this you may have to, it's a very shared decision-making with the patients, in terms of the logistics and so on. Now, assuming if we would do CAR T, would you consider bridging to address the disease burden prior to referral? Maybe Dr. Bakanova, if you'd like to take that one.
Probably. Just given that we know that less disease burden is favorable for outcomes. Also, it's going to be another 6 weeks before I get my CAR T. And this patient never had daratumumab, which is an effective agent. So it's a pretty low-hanging fruit. I would probably offer a dose or 2 of daratumumab to try to lower the disease burden. That may be one of the strategies, probably the most sort of reasonable.
Yeah, no, absolutely. So because of the current manufacturing time, and as much as we try to have a crystal ball, sometimes even in that first relapse, that rate of rise is not necessarily very steady. And, patients could have exploding disease, or they could end up having symptoms from the disease that could make CAR T treatment difficult. And I think in the second line setting, it's a little bit different than when CAR T was first approved in late relapse setting, where we would be concerned about what options, what other combination can we pick for patients. There are a number of treatment that the patient hasn't had, where given for a limited time frame has a very high likelihood of controlling the disease. So I won't go into specific regimens per se, but certainly in this case, this patient hasn't had a daratumumab containing regimen. So something with daratumumab and the next generation of IMiDs or proteasome inhibitor are certainly reasonable to consider. It will be interesting to see in the current treatment landscape. We've seen reports of many frontline studies as well, where that combination treatment up front is evolving. There's definitely a role for daratumumab use, or I should say CD38 antibody use, isatuximab studies as well in that setting. So really what you would consider in that second line is also evolving. Now, if we shift gear a little bit, this is in fact very much that same scenario that was in the first question when we opened the myeloma session. It's an older gentleman, now 75 years old, has had first line and also second line treatment now with daratumumab, carfilzomib regimen, and is now progressed. Would you still consider this patient? And so really, I think here is the question that was also hit a little bit earlier on in terms of, do we think about the treatment option differently in an older gentleman in this case?
So, well, the older may be frail, they may have comorbidities, and we know that CRS and ICANS are a concern with CAR T. If they have a high tumor burden, one could consider maybe a GPRC5D bispecific or alternative therapies to do debulking, but I would not withhold CAR from them. I'll find out whichever is available that they can have, because they can have both ID cell or cilta-cel.
That actually brings up a very important point, because the trial data that I presented are separate clinical trials and, different settings in terms of exposures for prior lines of therapies, as well as treatment agent. So we caution against really comparisons across trials. But we do know from some of the side effects profiles that based on that, you may consider one CAR T product a little bit more over the other for particular patient situations. And across the US, when the CAR T first came on the market, there was a lot of access issues. These are improving now. However, if a treatment center may have different access to CAR T, in general, if the patient's medically fit for CAR T, it's still reasonable to discuss that option with the patient, and probably at this point, less important for so much holding out for a particular CAR T product. That's how I usually think about that. Okay, let's see. We had a pretty much unanimous vote for CAR T before the talk. I hope that hasn't changed after my presentation, but let's see what the audience response is like. All right, everybody's still staying with CAR T. That's great. Thank you very much, and I'll hand it over to Dr. Pacanova.
Good morning, everyone. Thanks for joining us for this early morning session. I'm going to go on with our segment, and we'll talk to you about the clinical, practical implications and the growing evidence for outpatient CAR-T therapy. So everyone in the audience is now familiar with the timeline axis for CAR-T journey, which starts with a T-cell apheresis, potential bridging therapy, the lymphodepleting chemotherapy, followed by the CAR-T cell infusion and post-CAR-T monitoring. Models of CAR-T cell delivery have evolved since the pivotal clinical trials, such as ZUMA-1, mandated inpatient CAR-T administration and the inpatient management of complications. In this era, there is emerging evidence about the feasibility of a CAR-T. And so in the next few slides, I will review with you the experience so far and the framework it takes to establish the outpatient CAR-T cell program. So why do we worry about outpatient CAR-T cell administration? Well, what can go wrong? We know by now that the most significant, serious, and apprehensive complications of post-CAR-T therapy are cytokine release syndrome and neurotoxicity, ICANS. And these complications can become life-threatening. But there are other issues. There are infections, particularly bacterial infections and neutropenic fevers, potential for thrombolysis syndrome, cardiac, pulmonary, or liver kidney injury, and the rare but significant complications of the macrophage activation syndrome. So all of these are real, and that the early recognition and treatment are critical for the optimal outcomes. So the time to CRS and ICANS vary by the product. And this is important as we think about product selection for outpatient and a patient selection. So the time to CRS vary from 2 with axi-cell to 7 with the cilta-cell is up to 1 week. The onset to ICANS is significantly longer. It's typically a week. But in general, the real-world evidence now suggests that the new onset for CRS and ICANS after day 14 is exceedingly rare. And this information can be important as we develop monitoring guidelines and protocols for the outpatient CAR-T delivery. If we have to deal with the ICANS, can we prevent it? Unfortunately, the strategies to prevent CRS and ICANS have not been widely implemented, mostly because they are not that effective. The tocilizumab prophylaxis for CRS was tested in couple of small studies with a different timing before or after CAR-T cell, but proved not to be effective. In fact, it does increase the risk for ICANS, so this is not a good strategy. The steroids prophylaxis has been done in a cohort 6 of a ZUMA-1 study with 40 patients. This was a non-randomized observation. And here, indeed, the steroid given in 3 days immediately following the CAR-T infusion with axi-cell resulted in a less high-grade CRS, although it was still 80%, but no high-grade CRS. But there were still 13% of patients who developed high-grade ICANS. This, we just heard on this meeting some real-world evidence, which a larger number of patients is questioning this approach, and I think that more research is needed in this area. The anakinra prophylaxis is being tested in several clinical studies, again with a different dosing, different administration, and in one of the studies published, the ICANS was still developed in patients with a rates about 30%, although perhaps less frequently high grade. The most promising is JAK inhibitor itacitinib. It's a JAK1 inhibitor which has been tested in a randomized study in patients who are at high risk for the ICANS. And this study will be presented and has been presented in the meetings with a lowering of the ICANS but this agent is not available in the clinical setting at this time. At University of Minnesota, we have had a clinical trial using intrathecal dexamethasone used at -1 and +6. And this was combined with a endothelial protective statin orally. And this strategy seems to be promising. I think more research to be done, but we have not observed high-grade ICANS with this approach. And most recently, the Fibrotide was tested, but the study was terminated due to early failure of a primary endpoint. So if we cannot prevent it, do we have tools, or what are the tools which need to be developed to identify the patients at high risk of ICANS and CRS? Because if we know that we can develop strategies to really monitor these patients differently and be safely administering the CAR-T in an outpatient setting. So CAR hematox is one of the tools which was developed to stratify patients based upon a myeloid suppressive and bone marrow dysfunction post-CAR-T. So if you look at the ANC, platelet count, and hemoglobin combined with the inflammatory markers such as ferritin and CRP, you can calculate the CAR hematox score, and the high hematox score was associated with the prolonged myelosuppression and in some instances prolonged aplasia. This is not only important for the aplasia, but it is functional. These patients appear to have an increased risk for severe infection complications, 40% in high HT patients compared to 5% with low HT patients, more severe ICANS, and importantly, the non-relapse mortality appears to be higher in the HT high group. So this tool is particularly useful to calculate for each patient to predict his risk for complications post-CAR-T. In addition to hematox, there are other risk factors for CRS and ICANS which can be determined at the time of the pre-CAR-T assessment. They are patient-related, such as disease burden, inflammatory state markers, and ASIC score, which is more relevant for transplant, but has been associated also with the outcomes after CAR-T. Disease-related, such as disease burden, and of course CAR-T product, where the CD28 costimulatory domain CAR-T products are associated with a higher risk of complications. So these are relevant and important for the patient selection and monitoring frequency, especially if we think about CAR-T administration in an outpatient basis. The real-world evidence shed more clarity on monitoring requirements and implications for inpatient and outpatient selection. So this retrospective study across 9 centers involved almost 500 patients, and they indeed showed that early mortality is particularly due to ICANS and CRS, either in isolation or concurrent. However, the later one, after day 28, does occur as well and is predominantly due to infections, as we heard from Dr. Yi's presentation. So there is a really need for further investigation to develop not only individualized monitoring strategies, but also broader framework of a prophylaxis, which is based upon the risk of developing neutropenia and probably prolonged steroid administration. There's also a growing understanding of the risk for fungal infections, although it is quite rare, less than 1% reported in some studies. The meta-analysis, which looked at over 6,000 patients, showed that fungal infections accounted for 19% of infection-related deaths. So indeed, there are patients who are at risk for invasive infection. This has to be looked for, and prophylaxis is considered for patients who are at risk of prolonged neutropenia and have been on steroid with a prolonged course. So now I'm going to review with you the experience of using CAR-T cell therapy outpatient. Successful CAR-T program has to integrate multiple resources and aspects of care. the centers have to develop standard operating procedures for toxicity management. That's, I think, number one and the most important. For the patient selection and admission rules. The admission workflows, particularly reserved bed availability and workflows to avoid or minimize the ED visits. There are electronic medical records tools which can be integrated with treatment plans and flow sheets. The comprehensive education to support patients and caregivers, I cannot stress this enough. The education is really the most important for the outpatient rollout. The centers need appropriate infrastructure that's wide variable from center to center. Some centers have dedicated facilities, but there is a need for the multidisciplinary team and monitoring protocols, not only for the CAR-T and CRS, but particularly for the long-term follow-up, for delayed neurotoxicity, for delayed cytopenias, and for the prevention of infections. And so most centers also really benefit from the dedicated financial team, which supports reimbursement and identify payer coverage for the lodging and travel. So the first feasibility of doing outpatient CAR-T came from the UPenn group using TISA cell in a patient with lymphoma. They used bendamustine as a lymphodepleting chemotherapy, and this was in older patients, maybe in age of 66. Importantly, only a third of the patients who are admitted to the hospital with a median length of stay of 5 days. And the outcomes of this approach appears to be equivalent to the inpatient CAR-T administration. TISA-cel is particularly appealing for this approach because of the low risk of the CRS and ICANS, but similar outcomes have been published. From then, there is emerging and relatively quite a few of publications and abstracts in the meetings describing the single or multi-center experience with the outpatient CAR-T. Here is one of the series of 58 patients using commercial CAR-T on outpatient setting without any remote monitoring or wearable devices. This series include all types of CAR-T, although majority were cilta-cel. There was also axi-cel in a third of the patients. And the management included daily visits and administration of the tocilizumab in an outpatient setting. So indeed, as we see in this slide, the mortality rates were low. This proved to be a safe approach, only 1.72% in 1 month and 3.4% at 6 months. The 70% of the patients required hospitalization, but the length of hospital stay was shortened to 4 days, and this was also associated with improved patient satisfaction. So this study suggests that the commercial anti-CD19, but also anti-CD-BCMA CAR-T cell therapies are feasible to be administered in an outpatient setting in the absence of any remote monitoring or CRS interventions. So it takes a village to develop a program like this. The team needs to be well coordinated, well-defined communication, and they need to have good protocols to manage potential complications. The physician role typically is for the patient selection, outpatient versus inpatient, and toxicity assessment. But the team of a coordinator, nurse practitioner, physician, pharmacist, nurses, home care, family care support ensure the patient's safety and well-being throughout the treatment. So we have a follow-up poll question for you. Now you view this session and you should rate your understanding of a component of an outpatient CAR-T cell initiative. You have your answers there and you can start voting. So yeah, most people felt good or excellent about their understanding, and it's a complicated issue, and usually the devil is in the detail, so centers have a different threshold of confidence to roll out the protocols, and certainly I'm happy to talk to individuals about what are the particular strategies. The recent changes and new lessons learned in 2025 are something which I would like to close with. There is increased confidence in using CAR-T in both inpatient and outpatient, which led for FDA to relax the REMS training, primarily to remove the requirement for extensive education and to remove the requirement to report CRS and ICANS to FDA. With the real-world evidence, we also think that there is a time to relax the monitoring, and particularly for individualized decisions about when two patients can return home, less frequent monitoring after day 14, perhaps shortening the time where the patients are restricted from driving. The other interesting intervention for outpatient CAR-T administration was the use of the Portecath in the pediatric world. This has been a more established practice. It's quite controversial for adults, but certainly it's something which is important to explore. We need to continue to do research for the prophylaxis and potentially usefulness of intrathecal therapy or JAK inhibitors. I want to stress the important new warning in the black box for the CAR-T cell therapy, which is the serious complication of the T-cell lymphoma. And this is important to be watching for, people to be aware of, for the biopsies of the relapse disease are often useful and necessary. And more research needs to be done here to understand the underlying chip, which could be the risk factor in some cases. And we heard a lot about the shorter manufacturing, and this is important because it may increase the access to CAR-T cell therapy and really avoid the toxicity which are leading to the with the bridging therapy. So with this, I conclude the session, and we are happy to answer the questions, and the panel is available to questions after that.
Thank you very much, Dr. Bakanova. Thank you. We had an awesome series of speakers, and we have lots of questions. We'll try and get to as many as possible. If you have others, you can still send them in. So the first one will go to Dr. Yilin. Are there concerns about T-cell exhaustion, particularly now that we have a lot of bispecifics and we have a lot of CARs? And how do you think about that in either sequencing, or how do you think about that?
That is a really great question. And we have seen some recent publications for relapse setting post bispecific. So that is absolutely a phenomenon that can be seen in the way that we're currently using bispecific antibody as it's FDA approved, which is continuous treatment until the patient progress. So we can see the exhaustion of T cells, which you think can impact if you are thinking about collection and CAR-T manufacturing immediately following that. Now, even within bispecific antibody, there are many ongoing studies looking at fixed durations, looking at once patient achieve that depth of response, how to change the dosing frequency so that you're still maintaining the benefit, but maybe not have the T cell exhaustion. And that's even important just for bispecific antibody therapy on its own, because infection is actually even, especially severe infection, even more commonly seen with that agent. So right now, I think it is very much the question of, in the approved space, certainly CAR-T is approved a little bit earlier. The bispecific studies, I think the approvals will be catching up, so they will be concurrently available as well in earlier line setting. But when it comes to CAR-T, some of that consideration is, the earlier you're considering using it, even in patient who has ongoing myeloma, right? The T cell fitness unfortunately can decrease over the subsequent lines of therapy. And so that's why, one, we think about it the earliest possible opportunity in a medically fit patient. And two is, at this time, based on how these drugs are used and our understanding, if you think your patient is somebody that you would consider for CAR T, to then hold off on the use of bispecific agent, because what we've seen is with CAR T relapse, the bispecific can still have a better retained efficacy in that setting. So you're not removing that possibility, but for now, just consider it later in sequence.
Thank you very much. So there was one question here saying, okay, fine, shorter manufacturing, so what? It actually can be important because we know that the intent of when you want to give a patient a car and the number of lines when they eventually get the car does matter. In other words, if you intended them for second line, and you have to give maybe additional salvage therapy because of the longer time to manufacturing, then they're getting the car in third line. And we have evidence that the third line is not as good as second line. So that would be additional flexibility, or really why we need to get the car to the patient as soon as we intended it. Another question, Dr. Bakanova, is that so what do you say, or how do you manage patients? Because you do have a concern about long-term infections. What is your method to mitigate that risk?
Yeah, so there are some guidelines about antimicrobial prophylaxis for CAR T patients, which are published, and I think they are pretty generic and in general, and they are a starting point. We do use levofloxacin, fluconazole for some patients. It is important to have two considerations. One is really the use of the GCSA for patients who have a prolonged neutropenia, and whether that should be considered, and for what patients. We are using it for patients with a high hematox score to try to shorten the neutropenia. It is, in fact, sometimes effective. And the other prophylaxis question is whether when to use the anti-mold or invasive fungal azole prophylaxis. We have a couple of options there. And that's really an art of medicine to really select the patients. The guidelines typically involve prolonged course of steroids. For more than a week, it is something to consider. And then other immunosuppressive factors known for the patient, prior therapies, what are the other factors, why the patient is particularly suppressive. And you can also go by the CD4 count. If the CD4 count is persistently low, below 150, 200, then of course PJP prophylaxis and fungal prophylaxis could be considered. Although I would not want to stress the over use of the potent azoles. I think they have to be really used in a specific individual situations.
Thank you very much. So, Dr. Lin, second malignancies seems to be a risk for all autologous CARs. Do you have any thoughts about what to do to monitor for them, or any thoughts about that?
Certainly, that's a very important area now that we're treating more and more patients with CAR T. One, to understand, what is the incidence and the time frame that these may occur. So, generally, there are some broad categories I think about, right? There are common cancers that by receiving these therapy, you may have increased risk for. So age-appropriate monitoring for those. And then there are treatment-related, particularly hematologic malignancies like MDS, treatment-related myeloid neoplasm, where we know that the outcome can be quite poor and we have very limited management options. And so I think there is understanding, are there, for example, CHIP and other risks for patients that might be coming in that in the future may guide us in how we consider the risk of this treatment versus other options, or adjusted monitoring for that. And then there is the T-cell lymphoma that has received a lot of social media attention in the recent year, actually over the past year. And again, right now, based on what we have seen so far, we think this is by far the least common in terms of the incidence. But of course, that is a very specific risk from the CAR T therapy. And so it's really important, and there are many societies, including ASTCT and others, that's come out with some recommendations. One, it's very important to thoroughly investigate these T-cell lymphomas or T-cell lymphoproliferative disorders. By nature, it's actually a very complex diagnosis. So I think we really want to understand what are the clinical presentations in the spectrum of the disease. We need to understand, how does a CAR insertion is playing a role? Is that driving the process, or is it something that, with the general inflammation and the treatment, that is causing these things we're seeing? Because some of these have also been reported, for example, with checkpoint inhibitors and other immunotherapies, because these may also help us understand the treatment options in the future, and also how we would potentially next generation designs, right, of the CAR that could make it safer. I would say clinically, from a bedside perspective, treatment-related myeloid neoplasm is something we're already very cognizant about watching, warning the patient, because we're monitoring for cytopenias. And that's one of the things in the differentials that we are doing the workup for, if we're seeing persistent cytopenias. But for things like T-cell lymphoma and so on, it's really more about raising awareness. And when these clinical symptoms do present, that we are doing a thorough workup for them.
All right, thank you very much. We'll take just one last question. I know we are like a minute or two over. So one said, are there plans to expand CAR-T access to other continents like Africa? I don't know why they mentioned Africa in specific. I don't think it is available there, but it's in pretty much every other continent. But remember, with that comes some concerns about the turnaround time, about customs, and the rules in those countries. What bridging is available in those countries is complicated. I know it will happen, but it may take some time.
And just to follow up on that, I think, and there has been sessions at the Tenda meeting where we talk about point of care manufacturing. That's another model for CAR-T, and there are examples of that, for example, in Spain, I think in Brazil, India. And so this may be a different model for other countries globally in terms of access as well.
All right. Thank you very much for all. We could stay here and we will still be here a few minutes more, but I think in respect of other sessions, we will go ahead and close this session. Thank you very much for attending.